Loud and clear. Well, thanks very much, everyone. I'm pleased to see a small but select turnout, and I'm sure that you've self-selected to those who are very interested, perhaps, in global health and issues outside the UK. I'm really pretty impressed with Dundee, with your lovely table-style lecture theatre and your diverse range of ground round topics, so I think it seems pretty humane up here. So I am, as Tom said, I'm a public health registrar. If anyone's interested in public health, it doesn't get that much curriculum time in undergraduate or F1 and F2. So if you're interested, come and talk to me afterwards. It's a really good specialty. So I haven't, however, been in hospitals for a few years now, but my friends in A&E tell me it's getting pretty relentless and fairly dire in terms of queues and things like that. So if anyone's having to deal with the massive overcrowding, you will not be surprised, because actually there's only one doctor in the UK for every 357 people or so. So perhaps those queues outside A&E reception, etc., and AMUs is understandable. This is a waiting room in A&E in Malawi. This is one of the central hospitals, equivalent to 9 Wells, essentially. There's massive waiting queues there as well. However, these patients are probably the lucky ones. They're going to actually see a doctor today, hopefully, by the end of the day. And that's quite unusual. That's a rare event in Malawi, because there's only one doctor for every 28,000 people. So just in comparison, that is 600 doctors in total for the country of 17 million people. We've got 60 million people, and so the 1 in 350 people is looking a little bit better than Malawi then. So that's Malawi right there in sub-Saharan Africa. This shortage of doctors, this extreme small numbers of doctors in comparison to the population, equates to 10 obstetricians for the entire population in a country which has one of the worst maternal mortality ratios in the world. 5 gen meds. Is there any general physicians here? Yes. Oh, there you go. Look, this is the entire population of Malawi's gen meds right here in this room, essentially. Imagine, if you're feeling one off your feet now, imagine treating 17 million people with your skills. 4 general surgeons. You're more populous than general surgeons. 3 pathologists. Any pathologists? They usually like round rounds. No. 1 orthopaedic surgeon in a country where obviously the rate of RTAs is one of the highest factors in death. And 1 psychiatrist. Again, mental health has been shown to be a huge component of the global burden of disease, but in Malawi there's only 1 psychiatrist for the entire population. And no neurologists, no anaesthetists, and no haematologists. Any of those specialties here? No, it's a gentleman turnout. Wow, I can see. You're just attracting your own department. Yeah, twisting their arms, I can see. Obviously, this is bumped up a little bit by expats going to work, but that's not usually long term. So it's really, it's almost hard to kind of compute these kind of numbers because they're so stark. But essentially, this equates into most of Malawi's population never seeing a doctor and certainly never seeing a specialist. And that's not that unusual. This is a map of doctor density per 10,000 people, the proportion of doctors per population. The darker the colour, the more doctors there are. And I'm sure that's going to surprise you to see here up in Europe, we're pretty dark, over in the US, Australasia. But here in sub-Saharan Africa, pretty light, so not many doctors at all in a huge belt there. But India and Pakistan, pretty good. Not very many over here in Southeast Asia. Taking that all together, it's been shown, and some of you may have seen these stats before, sub-Saharan Africa has nearly a quarter of the global burden of disease, but 3% of the world's health workers and less than 1% of the world's financial resources to tackle these burdens, these challenges. So what do you think? So perhaps one factor which gets a lot of airtime in the press is migration. And I'm sure we all recognise that NHS just wouldn't function unless we had people who trained in other countries come here to work. So perhaps it's a lot of doctors who are trained in Sub-Saharan coming over to work in the NHS. However, this is a graph of NHS staff of foreign nationality and the different cadres, doctors, nurses, allied health professionals. You can see that in the NHS, almost half of doctors, these are all grades, locum and permanent conditions as well, and staff grades, etc., etc. So nearly half are from Asia, and nearly a third of those are from India. But those were countries with quite populous numbers of doctors. They were training a lot of doctors anyway. Sub-Saharan Africa, however, only makes up 6% of NHS staff, of doctors of foreign nationality in the NHS. So while migration is a contributory factor, it's not really the main cause. One of the bigger factors, and more important for here, is low production of doctors. The training numbers are absolutely tiny. So Malawi has one medical school. That's quite rare. A lot of other countries don't have any medical school at all. And it started in 1991 before students were coming over to Manchester, but because a lot didn't go back afterwards, they started up their own medical school at great expense, obviously. Medical training is expensive. But into about 2006, they were only graduating, dark liners graduates, light liners year one students, about 20 a year. In comparison, I hear from the students here, you've got about 150 or so in each year, is that right? Students up there? So for the entire country, only 20 doctors graduating each year. And that's only pushing up to about 100 per enrolment very recently. In comparison, UK, 33 medical schools and about 6,000 graduates annually. And that's because medical training is expensive. Each student in Malawi costs about $35,000 to train. Actually, I mean, in comparison to UK, that seems that's quite cheap. I think someone told me that I cost about $250,000 to train, and then about $500,000 by the time I'd finished specialty training. So each of us is a huge investment for the government. So although medical training looks a little bit better value than here, that's a huge amount of money for a country whose GDP is only about $250, so sort of £210 or so per person. So there's very little money to spend, and the health budget, the government's budget for health on 2014-2015 was only $125 million, and that's essentially less than NHS Tayside's hospital budget for the most recent financial year that I googled this morning. So the government has less money to spend in Malawi on health than NHS Tayside is spending on their hospitals. And of that, 36% is already going on salary. So health professionals are already eating up a lot of that, and training is taking up another 4%. So essentially, there's not much money to spend. So you want to make sure who you are training represents the best investment for these very, very limited resources. So you might think, I know you're facing the same problem here in Scotland, and there's rural practice fellowships, etc. Maybe you want to choose people who have a rural background, so they'll go back and live in rural areas, because you've got 85% of your population living in rural areas. Unfortunately, the junior doctors who I surveyed a couple of years ago, 4 out of 5, these are all the junior doctors 7 years after graduation in Malawi, 4 out of 5 had an urban upbringing. So that's not working at the moment. The rural population is not being represented. You might want to think about getting people who haven't been exposed to other countries, perhaps are less wealthy, will be more willing to work in Malawi afterwards. Only less than 2% of Malawi's population has a tertiary education. The same survey, I found that 4 out of 5 junior doctors, again, have at least one parent who have been to university, who have a tertiary qualification. And you really, obviously, you want to get the brightest and the most suited to medicine, wherever that may occur. So what you could do is subsidise tuition fees, so financial means don't represent a barrier to getting in and getting on with medical school. So the government has their subsidised tuition fees which looks like a very good deal, £550 per year. Unfortunately, in a country where the median annual salary is only £150, even £500 is just simply too much. Three out of 4 people are living in extreme poverty. More than 80% are subsistent farmers. They're just growing things to feed themselves and their family and not making any money out of it. So 550 is a huge amount of money. And what are the options? If you're a bright, ambitious student born in a rural village somewhere in the north of Malawi, what can you do? Well, you can ask your family for help. But unfortunately, if they're subsistence farmers or if you're a HIV orphan, you haven't got that resource, that support. You could ask for a government loan. Unfortunately, Malawi's economic situation is worsening rapidly, so the government have really diminished the amount of loans available. So you can't get those loans. You could try and working by the side, but I'm sure you all remember at med school how hectic it was anyway, just to get a couple of part-time jobs really impacted on your studies, and they're going to have to work a lot to raise money, so the students who are working are really impinging on their grades and often drop out because they're meeting academic standards, or you simply drop out. And actually, that happens to quite a number of students. So when I first visited Malawi, about 10 out of the 20 students faced financial barriers, and sort of 5 out of those 20 students were dropping out because of financial means for the sake of a few £100s a year. And this is where we come in. So this is a program that I set up when I was an FY1, Medic to Medic. So we essentially help that proportion of the population, those students who are bright, who are capable, but who are dropping out of medicine in their 3rd, 4th, 5th year for the sake of a few £100s, in a country where there are only 600 doctors. Every doctor is crucially needed. So it just seems such a waste of potential. We guarantee their tuition fees into graduation, give them various allowances, Oxford handbooks, etc., and a laptop to study optimally. And it works essentially like sponsor a child. We get doctors in the UK to sponsor a named medical student and follow them through to graduation, and they get feedback on their progress, etc. And that actually works both ways. We found that the students find the support that they receive from doctors elsewhere, particularly if they come from a non-medical family, which is pretty much all of our students. That kind of support really helps to inspire and motivate them, that the fact that someone out there is caring about them. So these are criteria for our students. What I was talking about before, we make sure that they have a rural background, that they haven't been to private school, that their parents haven't been to university or aren't doctors themselves, aren't professionals. They haven't got another means of support, so we make sure that we only target the most needy students. Preference for orphans, who make up a quarter of Malawi's children population, or single-parent families. Preference for female students, very low female representation at tertiary education and leadership positions, and trying to make sure that they want to work in Malawi after graduation. Obviously, that's difficult to set in stone, but we make sure that we get to know our students and select as much as possible for that. So this is Elizabeth. She is 28 years old and she's in the first year of medical school. She comes from a polygamous family. She has 17 siblings. And she took 10 years to complete her secondary education, get her A-levels equivalent, her higher equivalent, because she was working as a housemaid off and on in order to get the fees to pay for secondary school. So she eventually got the best grades in her district, got into medical school, but she essentially used up the rest of her money, the available money, to get to medical school, and then had no money left to register. And that's the point that we met her when she was 27. She'd won a place in medical school, but she was about as destitute as you can get. Now she's posing happily with her BNF and her Oxford handbook. All right, now I'm going to try a multimedia presentation. Let me see if it works. Oh, well done, thank you. All right, IT, over to you.
So it's just YouTube radio here?
Yeah, exactly.
So it's not getting any sound at all?
I don't think so, no, not at all. Talk amongst yourselves, chat amongst yourselves.
So all the standard stuff being checked, I take it, yeah, because this should just play.
Oh, really?
Yeah. Yeah, I mean, you never have to change stuff like this. It definitely has sound, yeah. the video definitely has sound. You've listened to it before.
Oh yeah.
The device is enabled. AMX. Yeah.
No.
Definition audio device. That's definitely the one we're looking for here. Copy video URL. Access. Let's try to bringing it up in another window. See if it makes any type of difference.
And that's up full, isn't it?
Yeah.
All right. Well, don't worry. We've got subtitles just in case, so we'll go over that. Maybe we'll just do that. Eh? Yeah. All right. Lovely. Thank you very much, IT. Just in case. Sorry for everyone in the remote sides. So we're going to do a silent medium, and just imagine this in sound, but we've got the subtitles. Right, so that was very interesting experience, wasn't it? It's like living with hearing loss. So here we go back to this. So that's one of our students. That's our physiotherapy student, Thomas. These are the results we have so far. So we have 54 students across medicine, nursing, physiotherapy and pharmacy. I know, Tom, you said that you try and get different professions along to the ground rounds. Our graduates make up 5% of Malawi's doctors. Admittedly, there's not many doctors, but we're still very proud of that fact. And all graduates except one are still in Malawi. One has gone to Lesotho, which is a bit annoying because every time I say that sentence, I now have to insert a caveat. And 3/4 are in rural areas. So this is the map of Malawi here, and as you can see, these are all the different districts, and we have graduates out from top to tail of Malawi, and in mostly the very rural areas which were underserved before. And these are a couple of quotes. So in the middle, you've almost eliminated the psychological pressure. The coming of the laptop has completely ameliorated the study pressure I used to face. Up the top, I'm really a changed person. Since medic to medic rescued me. Before, I'd spend a lot of time finding ways to get money on my own. And then finally, you're also making us role models for the young people in the community, especially girls in my setting. So this is a quick plug, I'm afraid, at the end. We would love Dundee to sponsor more students if you're interested. We've had feedback that it's very rewarding. We've currently got a crowdfunding appeal. I put the link up because tuition fees have just gone up. If you're thinking of riding, cycling, swimming anywhere, please get in touch, doing any kind of sponsored events. And we've got a Facebook and a newsletter if you want to do a more low-level activity. But in conclusion, from the educational point of view, there's a huge disparity in the number of doctors and all other types of health workers globally. In sub-Saharan Africa, the important contributing factors migration plays a part, but much more important are these low numbers of doctors and other healthcare workers being produced, and those who are trained dropping out before they graduate. And finally, providing financial and pastoral support to disadvantaged students, targeting those who may go back to rural areas or stay in Malawi, can improve those graduation rates and hopefully retention in Malawi. And get to this happy photo. So, thank you very much. Happy to